Well, hello, my name is Nilofer Azad, and I am a medical oncologist here at Johns Hopkins University at the Sidney Kimmel Comprehensive Cancer Center. I have been focused on taking care of patients with colorectal cancer for the last 15 years, and I'm very happy to be here today with Cancer Nursing Today as a roundtable to focus on colorectal cancer with two of my colleagues, Rachel Klein, who's a nurse practitioner who works at Johns Hopkins as well, and Fatemeh Youssefi, who is also here representing nursing that takes care of colorectal cancer. So I'd like to move into later line therapy for our colon cancer patients. So after patients have had FOLFOX, CAPOX, and or FOLFIRI, now we've got a new regimen with the Sunlight regimen, which is Lonsurf plus bevacizumab. We also have an FDA-approved agent in Stivarga or Regorafenib, and both are approved in the same line. So third line colorectal cancer, both are reasonable regimens. Fatemeh, tell me a little bit about your experience with each of these drugs and patients on each of these drugs.
So they are kind of tough on the patients as far as the side effect goes. And I think sometimes patients wanted to receive treatment, right? They have a cancer that's growing and it didn't respond to the first line, second line, and how you describe it to the patients. I think, again, it's fair to educate the patients, to put everything out on front, as Rachel kind of alluded to it, that these are the side effects. This is how you have to manage your side effect. And if they make a decision, just support them through that decision and help them with any side effect they may have. Again, going back to any GI side effects, any integumentary side effects, and provide and empower the institution to provide that supportive care if they need it, and empower the patients to call the providers when there's a side effect take place, basically.
Rachel, how about you? What do you educate patients about that they can expect with Lonsurf, bevacizumab as their side effect profile, with Regorafenib as their side effect profile?
Sure. So I will say, colon cancer patients are very, on the whole, my experience has been that people are very educated. It's a really incredible advocacy community. There's a lot of support groups, both online and in person. And I think people read a lot and try to understand the data as best they can, whether they're medical or non-medical or have experience with understanding statistics. And so when we get to third line therapy, I think a lot of people feel discouraged because up to recently, the data has been fairly discouraging. Maybe the overall survival or the overall impact for some of these third line oral agents hasn't been, what they would, as positive or as optimistic as they would like them to be. And so recently, when we've had this addition of bevacizumab with Lonsurf, I think we've been very encouraged to find improved overall survival benefit, improved progression-free survival, and importantly, in the Sunlight trial, they really included quality of life indications as well, which I think is really important in our cancer community trials. So people generally on Lonsurf plus bevacizumab have done better than with Lonsurf alone. And in the prior trials, people on Lonsurf did better than people on placebo. So I think we're building on this. And so I think in our practice, it's safe to say that even though both are approved in the third line, we've been trending towards this doublet therapy of Lonsurf bevacizumab as a preferred third line combination, because it does provide increased overall survival benefit without significant increase in toxicity. And I think that's really important. So Lonsurf is, as pretty much all of our cytotoxic therapies are, based on body surface area in terms of dosing. The standard dosing is 35 milligrams per meter squared. And that's given on a schedule of twice a day for 2 weeks, basically Monday through Friday of 2 weeks out of the month. So they get 2 weeks on the medication essentially and 2 weeks off. And then the infusion is given on day 1 and day 15 of each cycle. Patients that are used to coming in every 2 weeks, and as Fatemeh said, spending 4 or 5 hours in their infusion chair with their nurse or with their best friend or their spouse, will often find this a relief that they only have to be in the infusion chair for maybe an hour. And the bevacizumab is really not what adds significant toxicity. I will say the Lonsurf, some of the side effects we see would be fatigue. In particular, I tend to find kind of a cumulative fatigue that they're okay until the end of that second week, or maybe even into the first week off. They're finding that the fatigue in that time frame. We do see some nausea. It is an oral medication. It's absorbed in the GI system, so we can counsel on how to take it with food and how to best support them with nausea if that becomes a problem. We can see diarrhea. And probably most significantly, we do see neutropenia, significant neutropenia. And so we really need to counsel on the importance of monitoring for fevers, monitoring for signs and symptoms of infection, and frequently requiring the addition of a growth factor medication to help them stay on track with their cycles, so they're not having significant delays in starting cycle 2, cycle 3, cycle 4. But really, again, with open communication, and by this point, again, third line therapy, they probably have their supportive medication regimens down for the most part. It's not, everything's not new anymore. And so a lot of people know what works for them. And we just maintain open lines of communication on how we can best support them, make dosing modifications if needed, and hopefully allow them a little bit more flexibility in their life, being on an oral therapy, that they can travel, they can work, they can do what's important to them.
Yeah, I have to say, we were early adopters of the sunlight regimen based on the phase 2 data, even before the phase 3 trial was reported. And I have been so impressed by what I've seen in that regimen in the third line setting. This trial, which randomized patients to Lonsurf plus bevacizumab versus Lonsurf alone. The other thing that's really important is it's the first third line study that was randomized against an active comparator, right? So to what you just said, when Lonsurf was approved, it was randomized to placebo. Regorafenib was compared to placebo. So Lonsurf Bev did better than even an active drug of Lonsurf. And that, that median overall survival was close to a year on third line therapy. So, 10 and a half, close to 11 months. And then you mentioned one other thing that I think is really key about the Sunlight study, and that was that they looked at people's performance status and they had it graded the entire time patients were on study. And the median time for someone to lose 1 point to go from ECOG of 0 to 1 or 1 to 2, that was 9 months. So for 9 months, they maintained their performance status and lived their life just as they were living it, in terms of fatigue, in terms of activity level. And I think that when the overall survival is actually 10 and a half months and the median time to change in performance status is 9.5 months, that tells you that the majority of the time that they were on therapy, and even after they came off of therapy, they continued to feel better than they would have otherwise. So I think it's a really lovely third line regimen for our patients. Regorafenib, when, I tell people, Rachel's probably been in the room when I've said this, that it's kind of like having the flu all the time. For most patients, it's a little bit of low grade everything, you feel fatigued, you feel nauseated, you've got a little bit of diarrhea, got some nausea.
Body aches. That's a big one.
Yeah. So, and of course, there are people that do better, and we generally don't dose at the 160 FDA approved dose. We usually dose at 120, and we have definitely had people who go down to 80, 40 milligram tablets. But I think it is a more challenging drug in terms of quality of life.